there. Hi, everyone out there. Hi. I'm Mimi. This is Dr. Shepard. We're going to be talking about hormone therapy after age 60. So, Dr. Shepard, do you want to introduce yourself?
Yeah. Hi, everybody
Okay.
who is on. And even for those of you who are joining for the recording part of this, we are so delighted to be sharing space with you today. I'm Dr. Jessica Shepard, a menopause expert. And, I just really love what I do. I really focus on midlife uh, age and medicine and longevity. I'm based in Dallas, Texas. And last year I wrote a book on menopause, Generation M. So I'm excited to dive into this topic specifically because this is a question, actually, Mimi, that I very often
Yeah.
see kind of vacillating on the internet, as
Yeah.
they say. So
Yes.
you start off and maybe like both
Okay.
of your experience.
Sure. My name's Mimi, and I do not have a medical or health background. I'm a layperson. I am a person trying to figure it all out, just like a lot of you are out there just trying to figure it all out. And I'm 62, and I mentioned my age because I did start hormone therapy at age 60. And I can tell you my story behind that and sort of how I made that decision. I think I mentioned that I'm pretty deep in the Menno world or the Menno space. And as I'm going through and looking at what people are saying out there are so many questions and not a lot of answers. That's my observation, especially for women who are over 60 or past that 10-year recommended window of when to start hormone therapy.
Yeah.
So I think in my experience, I probably went through perimenopause, I think, in my late 40s, going into my 50s. Went through menopause at age 52. And so I'm looking at all of this in a rear view mirror because it's not even that long ago that there was so little information out there. So people like you, Dr. Shepard, being out there talking about it, it's much better now than it was 10 years, 15 years ago. But at the same time, I think there's a lot of confusion. I think there are a lot of questions and not a lot of answers. And so that's what I'm observing. There are people who don't seem to be able to get the answers they want. And I want to say, I don't think a lot of the answers are yes or no, black or white. They're
Right.
just, it's all individual. But I think one frustration is even finding a person to be able to work with to get that answer. So that was my experience. I think even just the subject of hormone therapy, I didn't even understand what was going on during menopause. I didn't understand kind of the mechanics of what was going on. I didn't understand anything about hormones. I just thought your period ends.
Right.
That's
Spanish, gone, out of here.
this just vanish, gone. And so I think the moment I started to find out more, I stumbled upon the book Estrogen Matters. I don't know how, but that was the book that kind of changed everything. Yeah, where I just started to dive in. But no, did you want to add to sort of what you're seeing out there in terms of
Yeah.
information?
No, I just love that you shared with your story. I think because that will resonate with so many people on whether they are, at your age, whether they're in their mid 60s or even in mid 40s, deciding what that looks like. I think the whole
Right.
landscape of HRT is very confusing. I think it's very nuanced in the sense that it's frustrating. You can't find someone who really does understand the art of it, what things can be taken, how it should be taken, how
Right.
long you can take it. So these are all conversations, obviously, that are becoming more popular. And even in those conversations, you will see how there are differences in how people agree or how they prescribe or what they're comfortable with giving. So it's kind of, I would say, even right now, a little bit of the wild, wild west, but in a good way that we're back on track with understanding that hormones are, in the end, more beneficial than causing harm. And,
Right.
sometimes I always think of like, a conspiracy theorist way in the sense of, Why is it that they were even given such a bad name that they would be completely taken off the market? And that's when I go back
Right.
to when it comes to women's health,
Yes.
we're fighting for it, right? And so, it's controversial, say, if you want to, call out medications, testosterone is for men, like there's risk that comes with that. But never once has it ever been that they were like, we're just going to scrap it. It's not, you can't access it. No one should take it. And no more chat about that. That has,
Yeah, when you look at it in that kind of comparison, it is a different perspective for sure. Yeah.
there's so much to that. And so, even though we're for a I guess you could look at it as the better side of it now, or, the more positive side of
Mhm.
hormones is that we still do have to, as providers, lovely advocates like you who are sharing their stories, is still there's so much more that needs to be discussed when it comes to
Right.
hormone replacement therapy. And I'll use that interchangeably just so everyone knows throughout the discussion with HRT, MHT, or even PET, which
Yeah, I mean, there's even kind of, bashing heads around how to
exactly.
what to even call it.
What do
Yeah.
you even call it? So
Yeah.
I'll
Yeah.
use HRT the most because I think most people are familiar with that.
Yes.
They all mean the same thing. But when it comes to me as a clinician and really looking at evidence-based behind what do we really do with that specific topic of women who are older than 60. So what I'll do is I'll kind of take it back a little bit into the story of how we even got there is obviously the WHI, which I try not to mention too much because I don't want us ruffle. But for context, is in that study, which actually was a great study in how it was formatted and for what they were looking at, which was heart health, by the way, is we have this community and we're looking to see if after a certain time frame of taking hormones, does it help with heart health or not? When they made the recommendations from that study, meaning who should we now offer hormones to, is women. It was either the age of 60, whichever came first, not after the age of 60, or when do you stop, rather, or 10 years after your age of menopause, which is 12 months of no bleeding, is when we term it menopause. So 10 years after that menopausal year, starting HRT, or not after the age of 60, either one of those,
Mhm.
whichever was
Mhm.
early. So that's where we really got this kind of stop. Like, this is when women can't have it anymore, shouldn't take it
Right.
anymore. And we kind of ran with that. And that was in a lot of ways that we prescribed, which we discussed, with women who were in the office of when they should stop. And so it did become a little bit hairy, if you can imagine, when women were maybe on hormone therapy or hadn't started yet and were over the age of 60 who were still having symptoms, right? I have patients in my practice who are mid 60s. I even have a few patients who are like in their 70s and still experience hot flashes, right?
Wow.
Exactly. Is it common? No, meaning in the wide distribution of
Right.
do most women will they experience that? No, but does it happen? Yes.
Yes.
And so, that's the thing with hormones is we don't get to cherry pick who should be on, who should be off
Mhm.
when they can stop, because then you are going to miss some people. Obviously, we need to be safe in kind of in that discussion of who should take it and who shouldn't take it, right?
Mhm.
But that age thing kind of really became this area in where we were like, oh, right, because we adhere to
Yes.
guidelines. We're like, you're 59, you're turning 60, you are gonna shut it
Sure.
all off. And so I can even imagine you and your discussions, to start, what did you find
Well,
is what it looked like?
I knew about that range,
Yeah.
and as I was approaching, because I was thinking about it in my late 50s, and as I was approaching 60, I felt like, "Oh, it's a race, like, I gotta figure this out, I gotta make a decision, I need to see decide what I'm going to do," and so
Not only that, it's like there's anxiety added to it. You're like,
yes, 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 and I think that's what I see so much, like, in comments, amongst people out in the mental world, is all this anxiety around the timing, the age, is it how long can I use it? Is it gonna affect what are my risks and all of that? And so there's so many of these questions, and again, very few answers. It's all individual. but I felt like I was in this race because of this timeline. And so I first approached my primary care physician,
Mhm.
and who I love. I
Mhm.
love I love my doctors. So I'm just gonna say that first. I love my doctors. And she said, I think I first approached her about um heart disease prevention or
Mhm.
something, because I do have that in my family. And she just said, "Oh no, we don't prescribe it for prevention.
Mhm.
Like, it's
Mhm.
not in the guidelines." And I didn't know that at the time. It was just something that I wanted to talk to her about, just because I was reading and seeing, I can't even say what was exactly based on actual research and evidence and what wasn't. I know there's a lot of research being done on brain health and things like that, and HRT. So she just flat out said no.
Mhm.
He said, and then around that time, I had kind of this little bit of a heart scare. I had to rule out having an aortic bicuspid valve, which I
Oh,
ended up
wow.
not having.
Mhm.
Luckily, I did not have it, but I ended up getting a cardiologist. So I asked her to prescribe it, and she flat out said no. Uh,
Mhm.
and then I went to an additional like hormone doctor, and she flat out said no. So now it's like 2 years later. I'm
Yeah.
back at my next annual, and then I had brought this article I had seen about the prevention of osteoporosis
Mhm.
with the use of HRT. And at that point, I had been diagnosed with osteopenia. I had had two DEXA scans at that point. My second one was worse than the first one. So
Oh.
I was kind of hovering, getting a little bit close to osteoporosis, and my mother had osteoporosis.
Mhm.
And so she said, "Okay, I'm going to send you to the gynecologist," and I know she prescribes hormones. And so I went through, health history, family health history. We talked about it. I didn't go into the decision lightly.
Mhm. Mhm.
And so I decided to start it then. And I was already 60, maybe
Mhm.
mm, getting a little bit closer to 61 at that point.
Right.
And so I started it. I felt fine. I use a patch and take progesterone.
Mhm.
And uh, this is not a recommendation. This is just my experience. But up until then, I had been having really bad joint pain. I have a herniated disc. I have some issues in my back, and I've had this back pain for many, many years. And so my entire body uh, hurt constantly. And I just thought it was all radiating from my back. I just assumed that's where it was all coming from. But within a week of starting hormone therapy, all the joint pain went away. It was like
Mm. Isn't
an
it nice?
unexpected bonus.
Isn't that like, this is magic? So I have
Yes.
few patients, um, who that is kind of like their feature, I guess you can say, of menopause, and they, again, after starting on HRT, MHT, really do notice a decrease in their joint pain. So they're,
Yeah.
even in addition to, you were talking about right now, heart health, there are so many other added benefits to
Right.
HRT that when I think of it, so I always like to kind of categorize it in a way of symptom, like something that you're actually experiencing that you're looking for resolution from, and then also quality of life, right?
Right.
And quality of life is, I have lots of people who, for the reason, we're talking about the age of 60, who don't want to come off of it when they reach the age of 60s because they
Mhm.
feel so much better,
Mhm.
right? So even if I did take them off, or they felt that they needed to come off at that age, they may not have a resounding return of symptoms, but then they feel that they just don't feel as good. And sometimes it's hard to put a name to it, or a title to it, or a price on that, but that's what they feel. And that's where, for me, I do feel that there's no um, age at which we can say there's a general rule for stopping, and
Right.
that was even written in the, I think it was the 2022 hormone therapy position statement by the Menopause Societies, where they were like, from what we know from studies, and I'll share a little bit here, is that there is no general rule for stopping hormone therapy in a woman based on just age alone, right? And that can go back to people may want to stay on it as a reasonable option for how they feel and longevity. And all of this should be done rather with appropriate counseling, right? So
Sure.
having a really nuanced conversation with your healthcare provider, and then also making sure you still go over the risks and benefits so that for the patient that they're making a decision for themselves based on
Yeah.
evidence and based on the questions that they ask, or what does that mean specifically for me when we look at the actual assessment of risk and what could happen.
Right.
And then, the other good part of that is we are seeing that when we look at studies, there's no direct link. And so I want to make sure that people understand there's no direct link that if I say, that's why, your cardiologist probably will, like, "Well, I can't give it to you for primary prevention of heart disease." But when you look at the studies that are done, particularly like the HERS study, or the elite trial, is that when we do look at it from an analytic standpoint and looking at sub-analyses, is that we can see that the outcomes, whether it's like osteoporosis or whether for disease, is that when they actually look at vessels like your arteries and your veins and then the heart muscle, is that the endovascular feature and then the endothelium of the vessels, like the actual arteries, there have been a lot of studies that actually show that it actually does help with those features of the heart, right? When we give HRT. And so they do have data that's, significantly shows it protects the endothelium of the vessels
Yeah.
in the heart and the brain, which is why there's also this correlation now that we start to talk about more with brain health. And it actually can increase your protective estrogen, which helps with HDL, which is a part of your cholesterol, and lowering your LDL, which is the part of the cholesterol that we don't typically want to increase and typically will increase with age, right? So we have a lot of features in studies which promote the use of HRT as a way to help with decreasing some of the things that occur with aging in other parts of our body, right? So it's a very nuanced way of listening to it. So I would never, like your doctor did never tell a patient, oh, if you get on HRT, you're not going to get Alzheimer's or you're not going to get heart disease.
Right.
But what I can give you is studies and information that help it break down to the level of this is how it's decreasing your risk for certain things.
Yes.
And that
That's
make the decision.
definitely what we did was we were weighing the risks versus the rewards. And then, then it's my job to see my gynecologist every year to keep with mammograms, also my ultrasounds. So, that's my job to stay on top of that, to always be sort of watching things and, making sure nothing goes off the rails.
Mm-hmm. Because the main thing is that heart disease is the number one killer of women. Like, you can put all the cancers together in a bucket, you will always win. So it is very frustrating when we look at it as, the doctors would be giving you something in the form of HRT that is like really risky for you, or really something that is going to like significantly improve your odds of death. Because automatically, just from an aging perspective alone, as women start to age, especially during the perimenopause and menopausal transition, their weight goes up, blood pressure goes up, cholesterol goes up, right? So in addition to the things that obviously make a lot of sense in how we maintain our livelihood or health, longevity, exercise and eating habits. And I know you love the movement part of that. That's why I love movement. And sleep is key.
Yeah, but the bonus of not having the joint pain enables me to do more.
But
Oh,
then, but
100%.
then look at that. Look at that fun fact that it was helping your joints, which allowed you to do the thing that you love more, which is movement, which actually is promoting your bone because you're jumping.
It's promoting my bone and promoting my muscle and,
Like all of it. Like you get a win.
the emotional part, the mental part,
Can we try a little bit? I love what you do. I love watching you, how much joy it brings. Can you tell for people who don't know how you started that? like how you started getting
Oh.
through that movement part of your life.
Oh. Well, I've always been active. I guess a lot of people say, "Oh, when did you start?" Well, I've always been active, I guess. Not in a lot of formal ways. Like even,
Mhm.
I taken dance classes throughout my life, but I was never, part of a company. I never auditioned. I never performed or anything like that. It was just something I always loved to do and just
Yeah.
kind of moved around and did different things. So like in college, I took like every dance class there was in college. In my 20s, I learned hip hop at Gold's Gym in Oakland. I was living in Oakland at the time,
Yeah.
and that was like just the most fun, like the best classes like I ever took. And then I was in the Bay Area at the time. I moved to LA. I was taking hip hop at the YMCA. And then when I was 40, I started ballet because
Mhm.
my daughter was very young and she was doing ballet, and all the parents would sit outside and just kind of watch all the kids. I said, "Well, I'm not going to just sit here this whole time." And I looked over, there's another class in the other
That's
like
great.
room. I said, "Well, I'll just go do that." So I did, ballet for 10 years. And then I started boxing when I was
Oh
50.
my God. You've
And
done
then yeah, I've been doing that for 11 years. And then shuffle, that's what I actually show a lot on my
Mhm.
Instagram. I started when I think I was about 58 or 59. And I just did that because I saw people on Instagram. They just blew my mind. They were just, it looked like they were like floating. And I thought, well, I want to do that. And I just started doing stuff online. So active, yes, always been active. Started um like weight training in my 20s, but didn't have any kind of plan around it. I would just kind of walk around the gym and just get on a machine, like whatever machine was open. That was, it was, and back then, it was all about aesthetics. You just
Yeah.
stay as small as possible.
Mhm.
And it wasn't until I was probably in my 40s, 50s when I understood, needing to build muscle, maintain muscle, build muscle, that I took it more seriously. So that's a
Mhm.
part of my um, exercise routine as well. It's just, again, I'm the HRT really, really helped in
Mhm.
that to enable me to do a lot of what I do today. I feel like I am stronger now at 62 than I was at 50.
Love that.
I'm certainly way more consistent at 62 than I was at
Mhm.
50. And when I had this pain, I would still kind of plow through and sort of do stuff that I wanted, probably not as much as I wanted, but I had like a whole protocol to be able to sleep at night,
Right.
like red light therapy, magnesium cream, ice pack, foam roller, stretching, and then I would still like be waking up several times during the night. That was terrible for my health.
Mhm.
And so it was just like trying to manage this pain. And I really, at one point, it was pretty bad. Like I had a hard time even getting in and out of the car.
Mm.
Standing at the kitchen sink for more than 5 minutes. I couldn't do that. And there was a moment where I thought, wow, if it's like this now, like in 5 years, I'm going to be immobile. Like this is
Mhm.
really bad. So like the way I feel about HT at the moment is like, sometimes I'll see a quote and someone will write, "You will not rip this from from my hands until like I'm I've left this earth." Like that's how I feel about it
Right.
right now in this moment. Um, in terms of the osteopenia preventing osteoporosis, until I get my next DEXA, like,
Mhm.
I feel like the exercise is probably gonna help that, and whether or not it prevents osteoporosis, that's we'll wait and see. But I I know for me, it's been great, and I understand, again, kind of s seeing what people are saying out there. It's not for everyone, and even if you're able to take it doesn't work for everyone.
Mhm.
You may respond in a way that doesn't feel good. So, I understand it's not for everyone. And I know I was like hearing a lot of voices out there saying, "Oh, and there are doctors out there saying, 'Oh, HT is for everyone.'" It's like, well, no, of course it's not for everyone.
Right. It's not.
It's individual. It's a decision you have to make with your healthcare provider. Hopefully, you can find one who will have that conversation with you. That might be something. I don't know if you have any observation around that, or even like in terms of training in medical school. Like,
Mhm.
are more people getting training in menopause? I know that's a problem,
Right.
and part of the reason you can't get answers is because
Mhm.
the doctors are not trained in this.
Yeah, there's, a staggering statistic of how little, when we think of percentage, that actually get adequate, right? So we all
Right.
go through medical school and learn about it from a physiologic standpoint and a pathologic standpoint of what it is and what happens to the hormones. But a lot of times, what I have realized, even in my practice and really focusing on midlife, is that it needed to be experiential. Right. And so, in order for it to be truly impactful on how I'm able to treat women if they do decide to do hormone replacement therapy, is to understand their story. Because if you
Mhm.
have a story behind it, or are unwilling to hear, kind of the journey that a woman is presenting with and going through, then you can obviously miss it. So it's not like hypertension or diabetes where it's focused on a number, right?
Mhm.
It
Mhm.
was how do we really create the ambiance and the ecosystem around the entire experience, because it comes in so many different features and formats,
Yes.
intensities and severities, and we just have to be willing to accept what that journey is for that patient. And
Right.
then if they decide to do hormone replacement therapy, what are the intended outcomes, or what are things that you can expect to happen versus how do we titrate up if you need that? How do we add in a feature if it's testosterone, or,
Mhm.
if you want to increase your progesterone, but change how you're getting your estrogen? There's so many different ways that
Right.
you can take in doses. It's not a one fix for all. And
I don't know if this would be helpful,
yeah.
but, maybe you could talk a little bit about the different ways you can
Oh,
take
I would love to.
therapy? Yeah.
Yeah, and I think that's important as well, because if you are going to see a provider and
Mhm.
you understand that there are various routes and how to take it, and maybe you're only being offered one or two, is that you can be like, oh, well, I know there's different ways to take it. Are we going over all the different ways just so I know what's available?
Mhm.
So, estrogen, because it's, I would say, our most vital, or it's the hormone that gives us the most vitality as women, is probably offered in the most form factor. So you can take it by pill, you can take it
Mhm.
by patch, you can take it by injection, but that's not necessarily one of the highest
Oh,
well,
wow, I didn't know that.
yeah,
Wow.
it's known
Uh-huh.
to be very popular, and I wouldn't necessarily
Yeah.
recommend it all the way. I said pill, patch, cream. You can take it in cream, and when we
Uh-huh.
say cream, you can take it systemic, meaning it's impacting your entire body, and you take it on your forearm,
Mhm.
or you can do vaginal, which vaginal estrogen cream is local, like it's just tending to the
Right.
vaginal tissue, right? So that's a little bit different. And then you can also do it in pellet form for those that are, can have it in a pellet, which is a compressed powder, and it has to be inserted by a doctor because it's in the fat of your buttocks where we put that. And all of those have different ways in which they're taken, as far as daily, is it twice weekly, is it
Mhm.
every 3 months? And then you have your progesterone. So, our progesterone, for anyone who's on estrogen therapy
Mhm.
and has a uterus, they have to be taking progesterone. Okay. And so that's
Mhm. Mhm.
important as well. And progesterone can come in what we call like a troche, like it can dissolve in your mouth. You can take it by pill, cream as well,
Mhm.
um, and also vaginal suppository. So you can insert it vaginally as a suppository as well. And then we have
Oh, I didn't know that either.
people. I have a few patients who are on it as a vaginal suppository. So yeah, it can be taken that way. And when we look at rate of distribution or kind of bioavailability of vaginal
Mhm.
progesterone, has a really good bioavailability. And then testosterone, which that one can be taken in injection, which most don't, but it can still be offered
Mhm.
that way. Cream, which most women probably take it in
Mhm.
cream form. And then that also can be done in pellet form as well. So that's why I was like, it's like a cheesecake factory to me. Like, as far as like what you can get, you can be like, I'm a little bit of
Yeah.
this, some
Yeah.
of them, and then you get to change. Like, I think, people feel
Right.
into the form factor that they take. and then they feel like
Right.
they can't change their mind, and you're like, no, you get to change your mind. So I think that's
Yeah.
one to understand that as well, or titrate up or down. But usually, I always recommend my patients start on a low dose so I can see how they respond,
Mhm.
and then start to increase. And
Mhm.
so that also is, so if you can already see with the ways that it's provided and
Mhm.
how you can titrate up or down, that there actually are beautiful ways to blend all three of them, or two of them, or one of them.
Right.
So again, it's not a one size fits all by any means.
If you were to prescribe a dose and you were thinking about adjusting that, like how much time would you stay on a dose before you would adjust to something higher or lower?
I typically, when starting, do like patients to stay on for at least 8 to 12 weeks,
Mhm.
because when they're first starting, they're really getting their receptors like used to now being exposed to this hormone. So I want to give it time, right? You have to
Right.
remember your body is like millions of cells. And so in order to get something done or respond, it's not like it happens overnight. It's kind of
Yeah.
like we're adjusting to, they're like, what's going on? There's something new
Right.
going on. How do we respond?
Mhm.
And so giving it time. And then usually when I have patients who have been on it for some time, adjusting doesn't necessarily have to wait that long.
Okay. All right. The patches worked for me. Big
Oh, I love.
fan.
Yeah.
Yeah. I'm actually surprised at how small it is. It's
Mhm.
really small. And so I change it every 3.5 days.
Great.
I have it in my I have an alarm set. I have it set in
Mhm.
my calendar every 3.5 days. And so I just move it from front left, front
Mhm.
right, back left. It just kind of goes around
Around in a
the
circle.
clock. Yeah, it's just in a circle. And I'm very used to it now. And, it doesn't fall off. It doesn't fall
Mhm.
off in the shower. It doesn't fall off when I work out. It's like for me, it's pretty convenient. And then progesterone at night, I take that at
Right.
night. But it's worked well for me.
Let's move to a few questions. I see a few
Yeah.
questions. Not that we had some
Okay.
ones that were sent.
Yeah, so we had questions sent in from the Perry community. So, Dr. Shepard, I'm going to ask you these questions because they're all sort of, very specific. Okay, so the first one is Marie asks, my mom is 70. She is not having any menopause symptoms, but she has osteopenia. Would HRT help her at this age to keep her bone, or is it going to dysregulate her body since she has adapted to post-menopause levels of hormones?
That's a great question. So I'll start with, what does it look like now that she's 70? Um, and what does that mean for her bone? So, because progressively, when we look at bone over time, when we start to see that decrease in the bone mineral density, and because she's 70, bone really starts to take a hit like in your late 30s, right? And then it kind of compounds and accelerates after the loss of estrogen. So at 70, I'll start with this first. I'll start with the good news first, is that it's never too late to start, right? And so absolutely she could start, but then when we peel it back to the layer of
Mhm.
how is it like really, really going to help, that's where we might not see as much
Mhm.
help as if she had started, say, in her 40s or 50s, right?
Mhm.
So that's where someone really gets to make the decision on, should I start or not? It's never too late to start, but the question also becomes too, what does that look like as far as what the bone has been able to do for now 20, maybe even 30 years without estrogen. Because
Right.
bone is living a living organ, and it has, turnover as far as to the cells turning over and being able to replicate themselves. And so when that is kind of gone, then that's when we increase our risk for fractures, because the bone mineral density has taken such a hit over a long time. So the goal really is fracture prevention at that point,
Mhm.
right? And osteoporosis is obviously going to lead to fracture prevention. So I always feel, that's why I'm like, it can be worth it to start it. It may not give you as much as we
Right.
see if you take it preventatively, but at that age, I feel like anything that you can do to offset uh, a risk of a fracture is
Mhm.
actually very important. And the reason why that's important is because postmenopausal osteoporosis impacts like 200 million women worldwide. And when you think of economics, quality of life, and actual death, like mortality, when we have a fracture of a bone, namely the bigger ones like a femur or, an arm bone, that is substantial because that's what actually for a lot of the financial burden on not only the healthcare system, but also a family, right?
Yeah, it's frightening.
Considerable morbidity. So I would say definitely that can help with decreasing it. We just may not get all the benefit we would.
Right. Okay, next question. Lori asks, how long can I safely remain on MHT?
Well, yeah, this is the perfect question because this is what we were discussing.
Yeah.
There is no age at which should be dictated to stop. I think that is when you start to look at what are my symptoms, but also how do I, as an individual, categorize this for quality of life and longevity? And what would I be willing to do when I know all the risks and benefits of staying on? So when I look at risk, I definitely know that staying on HRT is not going to increase your risk to outweigh a benefit. The benefits outweigh the risk categorically. And so I think it should be something that if you're going to stay on it, make sure it's a part of your like annual when you go into your doctors. It's like stopping, reassessing. What are we on? Do we want to change to another form factor? Do we still want to stay on? Do we want to increase our dose, decrease our dose? I think those are all part of the conversation as well. So it should be definitely part of an ongoing health conversation.
Yeah.
You get to change your mind.
It's not a one and done, right?
No.
Okay. What are some menopause symptoms tolerated by women that could be helped with HRT? Specifically, can HRT for older women help with symptoms like insomnia and the menopause bulge, or is it primarily for supporting mental health related symptoms?
Yeah. So if we're talking about it from an age demographic, and does it help with those things? It absolutely can help with those things. It doesn't mean that because you're older and you start HRT that it's not going to impact those symptoms. Most things or most times that we see some of those symptoms, which may be off-putting like ringing ears or joint pain or itchy skin that have to do with a decline in estrogen, obviously can be alleviated or ameliorated with the start of estrogen. Now, the other thing that I always tell women is it may not, but how much benefit would it be if we at least started and tried and it did? And then you get to press that easy button and being like, that was easy. Versus if it doesn't, I mean, you could be like, you know what, but I still tried it. And it is very hard for a provider to say to a patient, yes, it absolutely will stop that thing,
Right.
whatever that symptom is. But I always think it's worth a try.
Mm-hmm. Okay, next question. This is pretty specific, but can a nearly 80-year-old never on hormones benefit from micronized progesterone to help with sleep? And at what dose, 100 milligrams or 200 milligrams, knowing that it is probably also safe to use transdermal estradiol at 25 micrograms, but no doctor will prescribe it. CVD risk is low, but don't have a calcium artery score to confirm. Is it necessary before trying therapy? What would be the recommendations for starting so late? Understanding that the risk benefit profile is distinct for each woman.
Yeah, this is a loaded question. I think it's a good question. I also want to make sure that I make that disclaimer that I'm not giving medical advice for specific instances. But for a nearly 80-year-old, it would kind of go with the question that we asked earlier for a 70-year-old is there are benefits to starting hormone therapy at any age. Okay. There was actually a study that was done specifically looking at MHT beyond the age of 65. And what are those health outcomes when we look at a variety of different things, when we look at like all cause mortality, right? Like all the things that can cause someone to die. They looked at some cancers, cardiovascular disease, and dementia, right? And so specifically for the cardiovascular disease, what they did find that these women in general were only using estrogen. So progesterone wasn't in the picture, but obviously we would want progesterone in the picture if they have a uterus. Okay. And all of them, and they actually looked at it, they looked at like medical records, but they looked at 10 million Medicare women records over the course of 3 years. That's a lot, or actually more than 3 years, like almost 10 years. And what they found is that there was a significant risk reduction in all of those things that I just mentioned. And when we look at heart disease, it did reduce that, the disease part of it, and then all cause mortality as well. So I think that when we look again at the use of hormones, we have to understand that there is much more benefit to it than actual risk. And when we know now, we're much more comfortable, would be the word, at giving women over the age of 65 hormones, that it is worth. Now, the benefit that they're asking specifically in this question was for sleep.
Right.
You know that progesterone is more of like a relaxing hormone and can help with sleep. So I do think it's worth it. I'd always start at a lower dose before starting at the higher dose. So they're asking about dosing. I'd always start lower and then increase to higher. And when we do think of an 80-year-old with a risk that for cardiovascular disease that might be low, I would still say for someone who hasn't had it fully assessed, maybe doing things like an echo, EKG, some labs, and I think a calcium artery score is that can help, because that really looks at what the vessels are doing inside. And is that going to increase your risk for a potential blood clot? And would estrogen increase that risk as well? So that one is a very nuanced case. I think that that's where you would have to find a really good menopause expert to look at that, and in conjunction with a cardiologist who understands the benefit of hormone as well.
Yeah.
Making sure you get the proper testing and then making a decision.
Yeah.
Mm-hmm.
Okay. What is the order of magnitude of increased risk of complications like cancer, stroke, etc.?
Mm-hmm. That's a good question. I don't know. And I'll say that quite candidly of like what that order of magnitude is. When we look at the things that, typically impact women from a disease state or a morbidity state, we do know that cardiovascular risk. And when we think of cardiovascular disease, that really encompasses everything like congestive heart failure, strokes, heart attacks, clots, right, that impact like blood flow to the heart. So there's a lot of that encompass cardiovascular risk. I would say that probably an order of magnitude. So they're asking for complications. So let me just back up. So
yes.
So cardiovascular risk would be risk of complication, right? So you may have a complication from taking HRT, but again, the risk is lower than the benefit. For example, it decreases your risk of breast cancer. But when we look at colon cancer, but when we look at breast cancer, that's where people really get tied up a lot when we think of HRT use in the cancer. So when they actually did a retrospective analysis of WHI, one, it was a pair of hormones that they were using, which was equine form of estrogen and then synthetic progestin. Okay. And it was actually not the estrogen that increased the risk of breast cancer. It was the progestin. So when we look at progesterone as is it used today in HRT is typically the bioidentical form of progesterone. So again, when we look at risk versus benefit, I wouldn't necessarily say what is that order of magnitude. It really is what is your specific risk.
Right.
And it really should be down to what is your lifestyle, what is your age, what is your personal medical history, and then what's your family history. Those things are actually more important to what is your individual risk versus just saying of the paper that was done of this many people, yeah, see a risk of potential complications, but what's your individual risk?
Okay, here's another one. Yeah. How to reconcile hormone replacement therapy and endometriosis.
Yeah. So endometriosis is a disease that is what we call like a chronic pain, can be kind of chronic pelvic pain disease because of the lining of the endometrium and it going to different places and causing pain. Okay. So there's that. That's what endometriosis means. Now, endometriosis does respond in an inflammatory way to estrogen, which is why when we're treating endometriosis, we're typically looking at how to decrease levels of estrogen, which is then causing the pain or the implants or the release of prostaglandins. So when someone does ask that, it's a very valid question. What I have found both in practice and in research is typically the amount of estrogen that we're giving to someone who wants to do HRT is relatively a low level of estrogen, which typically may not increase the pain that comes with endometriosis because of the level of estrogen we're giving. The other part of that is because most women who are looking for HRT and have a history of endometriosis are older. So they're already on the decline of their natural source of estrogen, which may have caused the pain in the past. So you're already starting at a lower overall level of estrogen, which again may not incite the endometriosis to act up. So I have had a few patients actually who have a strong history of endometriosis. I give them all the same parameters on this may cause pain, but we have the ability to titrate, right, if it's too much. And you have to look again at the individual for why are they wanting HRT? Do they come in and they have horrific hot flashes, or their joint pain is really bad, or whatever the symptom is? How bad is it impacting your quality of life for you to decide, you know what, I do want to start HRT? And now endometriosis might be lower on the list of what we're looking for as far to address, and we can monitor that really well. Is the estrogen too high or low to create issue with endometriosis? And how is your quality of life here over with those other symptoms that you may be having? Because you get to show up for yourself. That is self-advocacy and being like, you know what? Because they can come on scales of, thank you so much. My hot flashes are all gone. I have a little bit of pain from the endometriosis, but I can deal with it because I'm much happier over here and decrease hot flashes, right? Or someone may be like, my hot flashes only went away a little and my pain is too much now. Let's decrease that or come off of the estrogen. So it has to be monitored, has to be discussed like in a comprehensive way. And you can't displace when people have had a really tough time with endometriosis because it really impacts quality of life for some people. And so I can't dismiss that.
Great. Okay. I do have one more question here, and then we have a little bit of time to go into questions in the chat. So if you do have any questions, put them in the chat now, and we'll go through what we have time for. So, okay. So here's one. This one's interesting. What specific insights should the pharma market research or prioritize to better inform messaging, education, or product development around hormone therapy for postmenopausal women over 60 who are often underserved or overlooked in current campaigns?
Yeah, this is such a big thing. So when you look at industry alone, I'll start there. And that's because I have worked with them in the past to understand what the research is for what the drug actually was made for. And I'll touch a little bit on that versus now, what is the messaging and who can it impact? So the pharma industry is very regulated, right? I'll give you kind of what they see on their end, right? I think sometimes we are unaware of what they have to go through as far as parameters to make a drug and put it on the shelf in order to be prescribed. And so when they do that, they always have to conduct a study to show that the drug that they made works for what they say it's going to do in a form of a study, okay? That's how the FDA approves it. And so when they do that, most times what we have seen is when we look at pharma, they research a certain category of women, like most likely to be in a category of a disease or a condition. And does this thing impact them? A lot of times you won't see outliers of like a whole distribution of women from like 18 to 65. That's a lot of women. It's hard to research women the broader you bring out some of these demographics. So the goal is pharma at some point is going to have to look at women's health in categories of this is the age frame in which we did this study, but now we need to extend that to maybe another study that includes women of a certain age category, which might be older. And then from that, they can then do better messaging, education, or product development because the study did look at that certain category of women and it got approved for that. Because if they're not approved for a drug for a certain category of women, they cannot do messaging or education outside of that. Then they would be, in the infringement of what their drug is. And they could be fined, taken off the market because they're going against what their drug specifically was for. So that's why that happens. So I do think at some point we need to advocate for because women are living longer, right? It's like
Yeah.
60, if you think about it, life expectancy might be 79, but a lot of women are living into their 90s. So that's actually a 30-year gap.
Yeah.
And so we do need to prioritize them in improving their quality of life. And that's why we do see decreased quality of life for women after 60, because we don't study them.
Yeah.
Yeah.
That's so logical and that makes so much sense, but it's very easy to kind of overlook or not have the awareness around that they can only say so much.
They can only say so much, right?
Yeah.
There is one more question that I you
Yeah.
private chat about testosterone.
I see.
I get this question so often because I think women are afraid to take testosterone.
Oh, I'm curious about this too. So can you tell me the side effects of testosterone? I do not use testosterone, but
Yeah, I like to.
it's kind of
I'm actually on testosterone therapy myself.
okay.
So let's start with that women do have testosterone.
Yeah, and they're also asking, is anxiety a common one?
Yeah. So what we do see is one, we don't need as much testosterone as men. I'm trying to get my thoughts together because the education behind testosterone and women take it and do they have it is where I'm trying to go. So yes, we can need it if we want. We do have reserves of testosterone that actually start to decline as early as 35. It's a very nice steady decline, different to estrogen, which drops a little bit.
Right.
More. And so with that is what we have found is it does impact things like muscle mass. It does help with heart health and also with cognition. Like I like to say, executive functioning, which clearly I might need some because I couldn't remember. But what testosterone is the hormone that it is, and typically men have more. The side effects that you can see, which again are not typical. I have a lot of women who are on testosterone who don't have side effects, but those can be acne, right? Because it's increasing.
Oh, wow.
Yeah. Hair and the oil production, right? Hair growth. That hair growth really can be anywhere, like on the face. And it's not like women like walk in like looking like Chewbacca and then they take testosterone. It's more like they might have a little bit more like fine fuzz. Some have like few coarse hairs that might come out. And I always offer them, I'm like, do you want me to stop you, bring down your testosterone, or keep it the same? Categorically, they'll choose one of the two of decreasing or staying the same. None ever want to come off because they feel so great off.
Wow.
Now, if it's too high, if someone is titrating someone and it's too high, they can exhibit hair loss, right? Because now when we think of male pattern balding, a lot of it has to do with testosterone levels. And so if you raise it too high, you can have a little bit of hair loss. But again, these are really high levels. And so that's why I'm like, it is very safe at low levels. I think when it's too high is when you start to see side effects. You can get a deepened voice. That's why males have a deeper voice, is because they have more testosterone. You can get clitoral enlargement. That's again, if it's too high. I've had one patient, hers wasn't high, but she just responded it into a way where she had a little bit of clitoral enlargement. I asked her the same thing. I see this. Does it bother you? And is it impacting your quality of life? And she was like, no. And I go, okay, well, we can decrease your testosterone. We can keep it the same, or you can come off. And she was like, I'll opt to decrease it and see what happens. And we did, and it decreased the clitoral size. And she's like, I'm good here. But she was like, what I'm not doing is coming off. So there was that. Now, anxiety, I typically don't associate anxiety with the use of testosterone. I see for patients who may have too much testosterone, they actually get more mood swings, more in the form of like rage, anger, right? Which is why men typically have more an anger issue sometimes. What we call like, like testosterone rage or roid rage has to do with testosterone and too much. So that can be a potential side effect more so than I would say to anxiety. Yeah.
Okay.
Yeah. Well, do we have any more questions? Because we're about
That was our last question, unless anyone else wants to throw one down in the chat. Otherwise, we can just kind of.
I want to give a shout out right
now.
Lovely Stacy Bryce Washington. Yes. I love boxing. She's amazing. Great platform as an advocate for menopause, and she showcases all the time her weightlifting,
Oh,
and
wow.
how she does that. Yeah, you should follow her, Mimi. She's
Okay.
amazing.
Okay.
And she has
Okay.
inspired like a community on her own to seeing as an everyday woman who understands menopause and understands the education behind it and sharing her journey. She is phenomenal. I love her and what she has done for herself and then also for women who look up to her. So I'm always giving her a shout out because she has
Oh,
a community called Shift Her,
okay.
and people love the content that she puts out.
Okay, so let's
Yeah.
let's all go look at Stacy. And then we want to thank Laura and
Yes.
Perry and
Very yes.
yeah, for hosting this. And there are other talks too, so you can get in there and sign up for additional talks.
Mhm.
And I think they go through the month of September because September is Perimenopause
It is.
Awareness Month.
Yeah.
Uh, uh, anyone else? Anything else? Dr. Shepard, this was really amazing. Thank you so much. I'm so
Yes.
glad that we got paired together.
I know. I'm so glad we got paired together because I'm like, I get like a tongue for a whole hour because you just light up my screen and I love watching. And I've sent like some of your like posts to other people. I'm like, watch this. Amen. Yeah.
Yeah, so okay, keep moving, everyone. Talk
Yes.
to your doctors. This is all individual, and prioritize yourself. Put yourself at the top of the list. Do what you need to do to make yourself feel great, and whether it's right for you or not, it's not right for everyone. But at least go out and have the conversation about it. I hope this hour enabled you to be able to put together some questions that you might be able to present to your healthcare provider to get the answer that you want, that you're looking for.
Yes. So I love that we were able to do this. Thank you so much for sharing your story. And
Thank you.
for anyone else who's watching live or they're recording, please
Mhm.
always start with the conversation and inspire more to advocate for themselves.
Mhm. Yes.
All right.
Great information, Dr. Shepard. Thank you so much.
Okay. Thanks so much. We'll see everybody soon.
Yeah.
All right. Bye bye.
Bye.